Benta lives on her own with 2 daughters in Mathare, one of Nairobi's biggest slum areas. Like her eldest daughter is HIV positive. Kenya is one of the countries worst affected by AIDS. In the slum areas, HIV prevalence is as high as 20%. 1 in 5 people is HIV positive. 50,000 children are estimated to be in urgent need of ARV treatment. Every Tuesday, Benta goes to the Blue House Clinic, located on the edge of the slum. Tuesday is Children's Day. Children under 15 account for 18% of patients, but the lack of adapted treatment makes caring for infected children a real challenge. The powders need to be mixed with water, and the syrups have a bitter taste and need to be refrigerated, so it's difficult to keep up treatment, largely because of the patient's living conditions.
The problem with the syrups being that some of them are not heat stable, so storage is a problem. It's also sometimes hard for the mothers to measure out the syrups because each drug is a specific dosage, it's not the same dosage. Then also most of these syrups cannot be used after 1 month when they are opened. And seeing as the setup that we're in, most households do not have techniques or fridges to cool these drugs. That has been the problem.
If medication is not administered properly, with underdosage for instance, drug resistance can develop, whereas overdosage will cause side effects. An alternative to the syrups has been available for a year now. It's a fixed dose combination combining 3 drugs in a single tablet, which makes it easier for children to take. But this is the only solution of its kind. When a child develops resistance, there is no treatment adapted to their needs.
For an average 10 kilogram child, this is what you would need to take for first-line treatment. 2 tablets in the morning and 2 tablets in the evening. They are small tablets, they're easy to take and they're dispersible. For a child of the same weight who is on second-line treatment, this is what they would need to take in a day. 6 pills plus syrup, which is quite a bit for a child to take of that weight, 10 kilograms, so the adherence is bound to be affected.
Most HIV-positive children become infected from their mothers, either during pregnancy, delivery, or the breastfeeding period. Yet nowadays, only 20% of HIV-positive pregnant women receive ARV treatment to prevent mother-to-child transmission. This was not the case for Benta when she was expecting her eldest daughter. She only found out that her daughter was HIV positive when she was 18 months old.
I was scared, and I didn't want to imagine that I could also have a child who is also HIV positive like me. Yes.
So how did you feel when you found out?
I really cried even at the hospital here. I cried, and it was Dr. Musa who tested this child. And Dr. Musa called me and told me it is not the end of everything. You are also living, and you are on drugs. This child will also live. She'll be given drugs.
10 years later, Benta gave birth to Caroline. To avoid contaminating her child, Benta is not breastfeeding. Throughout her pregnancy, Benta was followed by the team focused on the prevention of mother-to-child transmission.
Yes, there is information that we are being given at the PMTCT room when you are pregnant. There's some drugs that you are being given. When you feel that pain, that labor pain, you have to swallow that drug. And when you go to hospital, after delivering that child, you have to give her. Like her, she took drugs for 1 month.
When mother-to-child transmission has not been prevented, the solution is early detection. The sooner the child starts treatment, the greater the chances of survival. For the child, it's not only a fight against disease, it's a fight against the clock. 60% of the children who carry the virus die before their 2nd birthday.